This is going to be the renal gallbladder, or sorry, the renal and the bladder talk as well. And part of why we've included that word bladder is there's still so much pathology that we can find out from the bladder itself, whether it be from a volume status or a couple other things that you might see during your shift, whether it's with peds or adult patients. P.S. Even though we're kind of recording, feel free to shout out. You don't need to say your name or anything. And if anybody has a FIA thing, tell me now and I'll turn it off. Okay, we're all good. Let the record show no one raised their hands. Okay, so the reason that we're going to be thinking of doing a renal or urinary scan is for these main questions. Do I think this patient has renal colic? Are they in a new renal failure that I don't know the etiology of? Do I think that there's a catheter problem? I can't get it in, or now that it's in, I can't get it to actually flush well. And then that NYD, and that tends to be the catch-all bag, whether it's flanker abdominal pain, vomiting, retention, hematuria, fever. We still try to have a focus question there, but as with anything, we can broaden it a little bit in that regard. We're going to look at both, well, I should say more so the acute reasons, but some more chronic reasons that can have complications associated with them as well. So these are going to be the main indications why you're due it. Again, it'll be up on the website as a list that you can take down again. If we're looking at just the basic anatomy of the kidney, this is all that we're getting at. There is the renal capsule, which we tend to not see. There's a fascia just outside of it, so that, as well as the capsule, tend to appear bright white. Then there's the cortex, kind of like the actual working part of the kidney, getting into the medulla as well. And then we get into the collecting system, or the renal pelvis there. It drains out into the ureter. If there is something to write down in terms of kind of measurements that you'd want to keep in mind, this would be the length that we're looking at, as well as the width. And this is, again, in normal adult patients. We're going to flip it a little bit because this is more so how we see it when we're ultrasounding, whether it's on the right or the left. And this is going to be an image of one from the left side. You can kind of make out part of the spleen just to the, just right here on the screen. And then this right here is the kidney. Capsule, cortex, collecting system right here. If we're going to look at that a little more closely, if this were our patient and we have the marker pointing towards their head, where would their head be on our screen? Screen left, yeah. So lateral caudad, medial encephalad. And again, the capsule tends to appear hyperechoic there. We've got the cortex within this area, and then the collecting system. You might hear other words for the collecting systems, like the sinus or other things like that. It's all getting at the same point. And the collecting system tends to be hyperechoic compared to everything else. And for the most part, there shouldn't be anything hypoechoic or dark within it. You might see part of the renal vasculature there, but otherwise you shouldn't see anything. Our main technique for scanning, we're going to have the patient supine or in the lateral decubitus position. We're going to be using the curvilinear probe. And we got to keep in mind their hydration status, and we'll talk about a couple cases when that becomes important. In addition to that, it's got to be both kidneys, both in their short and long axis, and looking at the bladder as well. Now, I'll admit I don't scan the short axis as much as I should be. If I'm unsure if I'm looking at a stone or I'm already a little bit concerned about its dimensions, I might. But if my binary question is just, is there hydronephrosis or not, yes or no, I admit that I don't find as much utility in it if I can already get a good sweep through. If I've got a ribbon away that's just being a pain and then I need to rotate the 90 degrees, sometimes I will. Now, this will be the first thing that'll get me in trouble. If we're looking at kind of like how we need to have the probe itself oriented, I made up this story just about a dragon that goes to a spa. So if you'll bear with me for this one. So you've decided that you're going to give up medicine and you're going to work at a spa. And while you're working at a spa, a dragon comes in and the dragon says to you, okay, so I'm here and I just want the full meal deal. And you're like, okay, well, you're at a spa. Like, what do you want? And he's like, okay, well, I don't want you to touch my nails because that's what I use to like disembowel children in their dreams. and I don't want, I want you to, just trim my beard a little bit, but I want you to leave, my mane kind of long in the back. And you're like, okay, I can do that, I think, because I work at a spa. And so this is the idea. Let's say this were actually your dragon in the spa, right? So if you're just going to scan longitudinally, whether we're doing a fast exam or looking at a kind of the extended fast, if we were to go completely linear, or cut right through as a coronal, if you look at that dragon, he's going to be pissed off because you've taken out one of his talons, you haven't trimmed the beard, and you've kept the hair, you've cut the hair short. Whereas if you were to just rotate a little bit to be more in line with the ribs, you leave with a happy dragon. See, that made absolutely no sense. And this will probably be the one thing that you remember. Just make sure you make a dragon at a spa happy. It might have been super late when I made this slide, but anyway, we're moving on. And all that's just to remember that just like we could have small windows in a house, our ribs are acting like these little pieces of wall that we can't see around. So if you've got to jump up a rib space or jump down a rib space, that's much like thinking of we'll just hop from one window to another to see what's there. Oh, man. That was a good one, yeah. Thanks, Taft. Okay. When we're scanning, just to remember, too, that the liver is a bigger window, so we can see the right kidney a little bit more easy, whether it's an anterior, a lateral, or even a little bit of a posterior approach. Whereas that kidney on the left side, we've got such a tiny spleen that, again, like we were doing for the FAST exam, we've got to get that transducer way back touching the bed. You may even find that you've got to rotate the patient onto their right side, so left kidney up, to see it a little bit better. And this is what you'd see in the long axis for the kidney. And then if we were to rotate 90 degrees for the right kidney, this is what we'd see. Now with this view here, now let's say that we are lateral on the patient for our probe, and then we've rotated the probe, if we're looking at the right kidney, 90 degrees. Which direction should our transducer marker be pointing? Up towards their head or down toward their feet? Or sorry, up toward kind of the air or down toward the bed? Anyone? Air. Air. One vote for air. Any other votes? Okay, so gonna go with bed. I'm gonna suggest you rotate down to the bed. And the reason is that's more so gonna give you basically the same kind of mental picture of an axial cut through as if you're doing a CT scan of just that right side of the body. When you're on the left side, you keep it pointing up to the air. But on the right side, it's pointing down toward the bed. And we'll look at that on a patient before we start scanning, okay? When we get into obstructive uropathy, these are some of the types of stones that we can see. And obstructive uropathy is just when something gets in the way, whether it's intraluminal or extraluminal, stones being the most likely, so that urine can't drain out of the kidney, down into the ureter, and then into the bladder. In addition to stones, can anybody give me another possible reason for obstructive uropathy? Pregnancy? Like it? BPH? Aneurysm? Intra-abdominal mass. Super duper. Even things like if you've got someone who's taken a whole bunch of anticholinergics and they just can't drain that way. I've even seen it in elderly patients with constipation so bad that they get themselves into this problem. And so it's you got to drain one to drain the other. But these are some of the places that stones can get themselves stuck. And as you remember from the gallbladder presentation, bless your hearts, you all looked at it, how do stones tend to look on ultrasound? Hyperechoic with shadowing, yeah. And the same thing stays true for stones within the kidney. So if we're looking at the left upper one there right now, do you think the stone is in the kidney or in the tube or the ureter coming out of the kidney as we fan through it? Yeah, kind of at the junction, maybe a little bit lower. If we look right here, there, got something hyperechoic that has shadowing behind it. So that's a proximal, or a stone that's in the proximal ureter right there. How about on this one, on the right lower side? In the kidney or outside of the kidney? In the kidney, yeah. It seems as though we have something hyperechoic with shadowing in the lower pole of the kidney there. So this, out of these two, which do you think would be more likely to lead to symptoms? The one in the ureter. Yeah, that one we know is already going to get itself, or more likely to get itself in problems for obstruction. The one that's still within the kidney here, probably not causing an obstruction, but we know that that thing at any point can start showering little flecks off and lead to obstruction. So it's something we'll keep an eye on. Now there are even some super awesome stones, such as staghorn stones, which can be this size, not to be confused with the ever tasty and ever spicy ginger. I have ruined ginger for everybody. Some of these jokes are just for me, you guys. Thanks for humoring me. Okay. That is not going to pass on its own, no matter which way you twist it. Some of the abnormal findings that we'll see are going to be hydronephrosis. If you have a backup of urine into the renal collecting system itself. So this isn't getting into hydroureter like that first stone that we saw, and I'll have some clips of that, but this is just backup into the renal collecting system itself. So that's the urine distends the renal pelvis, and then as it gets fuller and fuller, it's going to continue to distort the kidney itself. So that initial space that we call kind of the renal sinus there, the collecting system, was it hyperechoic or hypoechoic? It was hyperechoic. But then the anechoic urine, as it backs up, is going to start stretching that out. So we'll see an anechoic portion within there. Okay? So this is a kidney that we suspect to have hydronephrosis. In addition to the hyperechoic portion here, we now have a hypoechoic center to it. So with the right symptoms, maybe they have blood in their urine as well. 63, with a history of renal colic, we might be more suspicious. What else could this be, though? What else looks anechoic? So cyst could, and we'll talk about cysts. The other one to think of would be blood. Is this that we've just caught the renal vasculature at an angle? Okay, so that's there within the renal sinus. Depending on which textbook you read, there's a grading system for mild, moderate, and severe hydronephrosis, and everybody has a little bit of a different take, so I'm not going to be offended if you read something else and it says something a little different. And even when I talk to the radiologist, part of it is subjective. There are these criteria, but then they'll say, well, we don't look at them. I mean, I've looked at 1,000. I just go with what I think is, this is being mild. I tend to think of mild hydro if you're starting to get these calyces and there's slight distension of the collecting system. In my mind, I think of it, if I'm looking at it, I'm saying, is there hydro there, but I'm not quite sure. And then I put on color flow, and it doesn't have any color flow, so that tells me it's not the renal vasculature. Then we're probably in the mild category. If, on the other hand, I look at moderate hydro, I've got a dilated renal pelvis, but no cortical thinning, so kind of the working part of the kidney is still looking normal. That's going to be moderate hydronephrosis. And I tend to think to myself, if I look at it, and when I first look at it, I'm like, yep, there's hydro there. I tend to think to myself, I'm already in the moderate category. Okay, and this is a cute little depiction of what they're trying to get at. If, on the other hand, you have a dilated renal pelvis where you're like, yep, I'm definitely in flavor country, but in addition to that, now you also have cortical thinning at some point, now we're into severe hydronephrosis. It's going to take more than a couple hours to get to this point, and you'll get different urologists who are keen to different levels on how quickly they need to address this. The main thing, though, is that you still want to talk to someone and you want to reach out to get a little bit of help here. So in this case, we can see here that it's hyperechoic, outer part of the pelvis that's been stretched, and at the superior pole, we're starting to have thinning of the cortex. This was actually on a, I think he was 8 years old. This is a little boy who had some pretty significant hydronephrosis, and we'll come back to his case at the end. Now, why we care about it is really from the point of view of looking at renal colic. That's going to be the one that we see most commonly. We'll still look at BPH and problems with catheters being blocked, but it's really renal colic. And there have been a number of studies that have looked at, well, can we use ultrasound more so to maybe have to forego the CT? We're getting better at having low-dose CTs, but if there is a way when we're working in rural settings or more remote settings, or maybe we just can't get that CT to start guiding our management, This was a group that still looked at formal CTs, but basically they were saying if you have hydro and a suspicion of renal colic, does it make a difference? And the answer was yeah. If you don't have any hydro, the likelihood that you're going to need surgical intervention is incredibly low. This was still done with formal imaging. They've had a follow-up study because they had kind of the, what's the word I'm looking for? Before the validation, the derivation. And then they've done, I think, a validation now, but there's been nothing external done to that regard. And it's still just at a single center. This was one of the slides that Chow had provided that looked at just the likelihood of getting yourself into trouble with the size of stone. Just like with gallstones, if it's less than 4 millimeters, you're probably not going to see it. The same holds true for renal stones as well. I got to tell you, I'm awfully poor at identifying them in the kidney. Every now and then I can find them in a ureter, but my uptake is far less than looking at things like gallstones. But this is one of the studies that came out that they looked at, well, if you have a stone bigger than X, Y, or Z, doesn't match with hydronephrosis. And so people have thought, well, maybe I can work my way back to saying, well, if they have severe hydronephrosis, is it more likely that they have a larger stone? Take from it what you will. All this to say, hydronephrosis would suggest that you need to get some imaging or call for help. No hydronephrosis, maybe you don't need to be as concerned. All that comes down to, though, is just, do they have obstruction? And then the other question would be, well, could it be infected as well? The second question that we're answering there, more so having to do with their labs and their clinical picture, but the obstruction, we can get some help from our imaging. Okay. In terms of bilateral hydronephrosis, it can happen. When you see it, tend to think about things that are lower down in the pelvis, so feel free to scan liberally. From anything like we talked about, the aorta, pelvis, oh geez, you have a second trimester baby in there, or two of them. And this is the differential. If I get this online, now's where you hit pause and you take this down, or you can just tickety-tap it out right now. But there are a lot of things there. Questions so far? Still good? Okay. Now, there are some mimics of hydronephrosis as well. We talked about a couple of them already. There are prominent renal vessels that we can see. You can get cysts both within the pelvis as well as outside of the pelvis. You can get chronic reflux, which can basically lead to problems as well, and then papillary necrosis. I confess I have never seen papillary necrosis, so I'm not going to be able to tell you any more other than keep it on a differential. Please call for help. The reflux, that's something that you'd see more in pediatric patients, and really it's just that you're going to have a constant bit of fluid in there. And then cysts and the renal vessels. So looking at the cysts, these are the parapelvic ones, and all that they're getting at in terms of parapelvic is that they still find themselves within the pelvis there. So you can still see a hyperechoic portion of the pelvis around them. They tend to be circular or kind of roundish, as opposed to the irregular shape that hydro would have. And hydro will tend to follow out into the major calyces, the minor calyces, and then up into the cortex as well. In terms of the renal vasculature, as I mentioned, you can look at the kidney, and then if you put color flow on and then everything lights up like a Christmas tree, well, you can say, well, that's actually just the renal vasculature. If, on the other hand, you have that look at the kidney and you think you put on the vasculature and it doesn't light up, then you know that you're looking at hydronephrosis. Okay. A caveat here too is just make sure that your flow settings are set low. This is down at 12. If for some reason someone had it high at like 30 or 50, you might get a false reading for it, a false negative reading. So just make sure that that's low. Guys, P.S., we're actually getting near the end already, so this is super awesome. Hydronephrosis, as we talked about, there can be a secondary cause, AAA, as we mentioned, that differential, and then there are also other inflammatory things that can be going on in the bowel. If they lead to irritation of the ureter so that it gets tight and blocked, diverticulitis, appendicitis, also keep on the list. There are renal cysts that can look like hydronephrosis as well. These tend to be their characteristics. I'm not sure if this might one day be an exam question or not, but again, this would be the point to pause and take these down. They need to be anechoic, well-defined, near the surface of the kidney, no wall thickness, no flow, no septations. And I also put down their number less than 3. If you have more than 2, you tend to start thinking about things like polycystic kidney disease. That should warrant a definite follow-up ultrasound as well. And I tend to think of these as if you can make out that they have started kind of within the cortex and then they balloon out to whatever size, and then they hit all these criteria, I'm happy with them. I'll write it down as an incidental finding. About half of the people above 50 years old are going to have them, so it's just one of those things. Sometimes someone can have kind of a hemorrhagic transformation with one of them. So again, if they don't look anechoic, that could be what's going on, and you should get them imaged. And this is what they look like. They're just small, little cysts. But then again, they can also be much larger ones as well. If it doesn't meet these criteria, again, you've got to think about other things like tumors or other issues like that, so get formal imaging. This is a collection of giant ones. Now, would these be off of the lower pole or the upper pole of this kidney? Just trying to keep our orientation correct. Lower pole, yep. So are they thin-walled? They seem to be. Anechoic? Yeah, we could put the color flow on to confirm that there's no color flow. There are no septations. It almost looks like there's a septation at this point here, but that's actually 2 different cysts. And then there's no real internal architecture. They can be so big, though, that this is actually a significant case of polycystic kidney disease. The normal renal architecture is pretty much tucked down here, and then you just have a continuation of dozens of cysts that continue on up as well. Okay. I don't have any examples of any renal tumors that were that great. In addition to getting hydronephrosis, if the stone or the obstruction can trickle down further, you can get a hydroureter, which is just a backup of urine within the ureter itself. So in this case of this kidney, you can see that you have dilation here into the pelvis, and then it seems to continue down outside of the kidney. I followed down this patient a little bit further, and you can see this ureter comes here, and then it wraps itself around here like this. This was actually in a lady who was postpartum 3 weeks, and she's like, I was told I had kidney stones before. My left flank still really hurts. And I was like, you look like a peach. I don't need to do anything. And then you scan and you find this. So that's what we did. Got her a formal imaging and got her in touch with urology to help remove a stone. Now, positive fast, yes or no? And why? So if I'm asking if there's a fast, it means there must be fluid here somewhere. Does everybody see? Yeah. So, it's not a positive fast. Okay. So not a positive fast. So what makes you say that it's around the kidney and not around the liver?
Well, I can't remember what the different fascial planes are, but it's basically a thin strip
Good.
around the kidney. It's not going to be communicating.
Yep, you're right. And it's Gerota's or Gerota's fascia. And you're right, we have this thin strip right here. And you can see it kind of track around even a little bit right down here. And there might even be a little bit medially here. That fascia is going to encompass all of the perinephric fat. So if the fluid's around the perinephric fat, it's got to be contained within that space around the kidney. So you're right, it's fluid around the kidney. The differential diagnosis for this? It's going to be some type of fluid that's anechoic. Blood, urine. I mean, I guess it could be a heck of a lot of pus somehow, or maybe a popped cyst. I tend to think of urine, in which case that would be a urinoma, or like if you have such bad hydro, then it expands to the point that it pops through a part of the cortex and the capsule, and then it kind of leaks out there. That's a problem. I suspect that patient would present with an increasing amount of pain that then suddenly just gets a little bit better because the pressure's been taken off. Or in a trauma patient, potentially you could get this as well. And it should follow the contour of the kidney. Quickly, just about the bladder, anechoic structure that you're looking for just above the pubic symphysis. We want to measure it both in a transverse and a longitudinal plane. And then if we're looking at it for volume, we want to measure its depth, its width, and its height. And depending on who you talk to, you're going to take the height, the length, and the depth, and then you're going to multiply it by something between 0.5 and 0.8 to figure out the volume. I've seen 0.5. I tend to use 0.75. If you get a really distended bladder, I mean, it's not a perfect any type of shade. It's like kind of like a partially filled water balloon. So choose something, stick with it if you're going to be looking at the same person for comparison. But it is, it's a little bit of a moving target. I don't know if anybody has another number that they use. It can be all over the place. Okay. We try to be centered right over the dome of the bladder when we're scanning in that regard. And be aware that it can extend quite highly as well. The next one's going to be a view in the long axis of the bladder. And what do we have there? We've got a Foley, or a cute little person giving the middle finger maybe, but it's probably a Foley. I'm not going to be able to cut that out of the presentation. Why did I say it? Okay, so that's what a Foley looks like. So if you're wondering if you have a Foley in place or not, we've got a Foley in place, definitely. Or you don't have any signs of urethral trauma, but you want to do a fast exam on someone who's unstable and they have a Foley in, you might instill it with fluid, and before you go in, you can confirm that the Foley's placed and then put some fluid in there as well. Urine jets. Has anybody heard of urine jets? Yeah? What have you heard them used for? Nothing, anything, everything, party trick. Rule out obstruction, yeah. Yeah, they can look like a little flame. Depending on how you have your gain set, sometimes you can even see the swirling without the gain. But the other thing that you can do is you can put a color box on, and you can watch these little kind of flares, these little flames come out from either side. On this patient, this is in a transverse view, and we can actually see both of them. Now, jets can rule out a complete obstruction. They can't tell you anything about a partial, but they would tell you that there's no complete. But on the other hand, the abscess doesn't rule in an obstruction. And the most recent paper I looked at said that, I mean, you can have in a normal patient, you can have up to like 4 minutes between urine jets, and I am not going to spend that time, and please no one spend that time looking for that. So it can be partially helpful, but don't think that it's the be-all, end-all, and really try to keep a binary question in that regard. This is now the brief pearls and pitfalls on this. We didn't get into some of the weird and wonderful stuff like resistive indexes or anything like that. It's just more so binary questions. Is there hydronephrosis? Yes or no. Is the bladder full? Yes or no. Does it have something in the bladder? Yes or no. And what is the approximate volume? The pearls and pitfalls we wanted you to know is just remember to scan both kidneys. Obviously, keep in mind other things that can be on your differential for hydronephrosis. Trying to continue to recognize minimal or mild hydro. Ruling out other obstructive uropathy based on the absence. If your patient isn't well hydrated, it might look like they have no hydro when once you fill the tank, suddenly it's quite apparent. The degree of hydro doesn't necessarily correlate with the degree of obstruction, and this is just to say that even though we looked at kind of that one graph, just because it looks severe doesn't mean that it's going to be a giant stone and a creatinine of 1,000 that needs to be addressed 30 seconds from now. You still need to talk to some colleagues, put it in context, and get your other labs. Just because it's visualized doesn't mean it's going to be the source of pain, like some of the smaller ones you'll see in the poles of the kidney. Many causes for hydro, keep the differential broad. And always think about this when you're looking at reasons for renal failure.